All right, recorded. All right. Hi, everyone. Here I am again. It's Tao. It's been a while since I'm doing it again. And this time I'm here hopefully to just help myself read every single slide that is important for exam 2 on radiobiology. So without further ado, let's get started. Let's share screen here. There we go. Just gonna bring myself down here. Okay. So exam number 2 covered chapter 18 to chapter 22 of radiobiology. And I went over chapter 18 yesterday, but unfortunately is recorded via MacBook recording, and unfortunately it is not recorded my voice. So yeah, here I am again on Zoom. Let's get started. Chapter 19, dose response relationship for model normal tissue. I'm just gonna, there we go. That would help. And this figure 19.1, as you can see on this figure here, on the left side is tumor control percent, right side incidence of normal tissue damage. Both is ranging up from 0 to 100 with the interval of 20%. Dose is ranging from 0 to whatever it is right here. This figure is representing the dose response relationship, and it is sigmoid shape for both tumor control and normal tissue damage. That for normal tissue damage may be steeper than the tumor control. So saying the normal tissue damage is steeper than the tumor control, the therapeutic ratios or index is the percent of tumor control that can be achieved for a given level of normal tissue damage. In this hypothetical example, about 30% tumor control can be achieved for 5% incident of the normal tissue damage. I don't exactly know what that meant, but let's remember 30% tumor control and 5% incident of normal tissue damage. So I know from Dr. Mensch, my radiation biology doctor and professor, said we really want these two sigmoid curves to be closer together as possible. This is our goal. Red one is tumor control, blue one normal tissue damage. So the higher the dose, the steeper the curve, as you can see over here. A couple of questions on the slide is which is more radiosensitive? Obviously, radiosensitive is the ability of cells to become sensitive to radiation, which is really beneficial in radiation therapy. So we can treat tumor. If tumor is radiosensitive, we are being able to treat them, being able to destroy them, shrink them. But if it's radio resistant, it's really hard to get radiation to shrink the tumor. So obviously is the red curve that is more radiosensitive. And if normal, the second question is if normal tissue curve is steep, what does that mean? Normal tissue curve is steep. That means that I will have to go back to this guy. Sorry about that. small, and third question, small increase in dose gives blank increase in complication. Increasing dose give a large amount of increase in complication, as you can see right here. Going from 1, 2, 3, 3.5 to 3.8, I guess, or 4. You can see the steep low slope right here on normal tissue damage. Increase a large amount in complication, I would say. Can we do anything to make it less steep? Yes, what we can do is we can control the tumor, get this curve. Basically, if we talk about this graph, we can get this blue curve, which is normal tissue change, closer to tumor control. So it's also said right here, hypothetical example, about 30% of tumor control can achieve for 5% incident normal tissue damage. Early and later responding tissues. Tissue effect depend on cell turnover and function. Early responding tissue and late responding tissue. I kind of put this slide into a docs. I'll show you later. So the way I study is I divide that concept into parts and charts. I'm a chart guy. I love table and charts. I just want to put everything into table and chart. It just satisfies me if any wording document would put into table and charts. So bear with me. Early response tissue has alpha over beta, which is the fractionation sensitivity. For around 10 grade, and its effects takes weeks to months. See at the end of treatment, normally if we link into my patient, you will see patient for example, for breast treatment at the end, like for example, if they have about 35 treatment for breast cancer, patient using tangents field, you will see their responding, their tissue responding to the treatment. It can be, you can often see is the redness and their rash. Some of them have the dry rash, which we call dry desquamation in radiation therapy. And dry desquamation is okay, but then when it get into moist desquamation, you're gonna see it's clearly that the breast tissue has been moisturized and wet, and it's really hard when they get into that stage of desquamation. It is really hard to reverse. Can be challenging. It is reversible, but it's challenging too. So, and it's also affected skin, intestine, bone marrow. There's 3 specific type of tissue that I listed in my chart, and it's gonna help you remember the name of these type of tissues later on. And for late responding normal tissue, so this is for normal tissue though. This is not tumor tissue. Just making sure that we are, for chapter 19, we are still talking about normal tissue. Later on, we're gonna focus and compare between normal tissue and tumor tissue. How radiation affect this normal tissue, how radiation affect tumor tissue is differently comparison. Late responding for normal tissue alpha over beta, about 3 grade. It has effect, can take months to year to develop, so it's take longer time. It's not grade to month anymore. Mostly affect lung and kidney. And recall that alpha beta, they are fractionation sensitivity That was one of the test questions that I got in a previous exam. Experimental techniques for dose-response relationship. We have 1, 2, 3. We have the functional, the reproductive integrity. We have functional response. We have inference, reproductive integrity, or clonogenic endpoints, cell remaining that can successfully reproduce. Functional response is erythema, which is the redness of skin, pneumonitis, fibrosis cells remaining that keep organ tissue functioning. Inference, dose response curve, assume the form of dose response, linear quadratic, perform a series of multi-fraction experiments, infer values of the alpha over beta for normal tissues that parameters cannot be measured directly. Another figures, I'm telling you, this class is the figure class because we learn stuff via figures and charts, and you gotta be able to tell each and every single one of those curves what are they represent, and the relationship between them. So hang on there. Here 19.25 dose response curves for the induction of hind leg paralysis in rats following irradiation of a section of the spinal cord from L2 to L5. Note how the dose necessary to produce paralysis increase rapidly with an increasing numbers of fraction adapted from van der Kolk leg effect vibration on spinal cord, blah, blah, blah. So on this y-axis, we have rats with high leg paralysis percent. X-axis, we have dose. Gray is the unit of dose, ration dose. So for single dose, we can see it is traumatic. This is tremendously gonna cause rats to be paralyzed. It will give them single dose, and look at it. It's not really. It's nothing compared to these doses down here. So it's really small amount dose, and it's already get the rats to be paralyzed. If we give them a single amount of even smaller dose, it can be very lethal to them and cause them paralyzed. This is for 2 fraction, 3 fraction, 5 fraction. So it slightly is improving if we give them radiation through fraction rather than a single dose, as you can see here. And those are more bigger, like way bigger fraction for 10 grade, for 10 fraction, 15 fraction, 20 fraction. Look at it. If we use like the more fraction that the higher dose that we use, the more fraction that we divided into. So for example, fraction is just days that you're gonna get radiation. So for example, you can choose to get radiation on one day. For the right here, this is 18. 18 grays for a single dose. It can paralyze you right away after that dose. But if you give patient 40 gray, which is it's considered large amount of radiation, but you divide it into 10 days. A fraction is just days of getting radiation, so you divide it into 10 gray, 10 fractions, so 40 gray. We're gonna divide it into 40 by 4 by 10, it's like 4 gray a day, is still a very not realistic amount of radiation that we give to our patient, because we cannot exceed for normal treatment, we cannot exceed the radiation amount from 1.8 gray to 2.0. So basically what they do here for the rat is very brutal, cruel, I would say. So moving on, I think we get the hang of these figures. It's really easy to understand. Next one is linear quadratic model of choice. This is one of the really very important figure. Their model for radiobiology. We keep talking about it again and again. So we have to make sure that we get a good understanding of these models. Most accurate and validated by experimental clinical data. Typical therapy doses around 2 gray, as I tell you, is about 2 gray that we try to get patient standardly not over 2 gray for their whole entire treatment. It can be used to estimate equivalent radiotherapy schedules. Deviation from standard fraction protocol affects outcome. It can predict tumor control, tissue communication, and depends on parameter alpha, beta, and alpha over beta, which is fractionation sensitivity. We come up with this formula, which is S equal e to the negative of alpha d minus beta d square. Alpha over beta estimates perform multifraction experiments with specific n to infer alpha over beta to a larger, earlier responding tissue, about 10 grades. 10 grade is early. So what you have to put in mind is these number. If there is a question that having you calculate their BED, then you will have to use these alpha over beta ratio accordingly. So if it's mentioned early, you gotta use 10 gray. If it's late or smaller responding tissues, 2 or 3 grays standard. Like ideally, I would see 3 gray would be the ideal number that we want to use in that problem. At D equal alpha over beta, linear and quadratic components of radiation damage are equal. And dose response relationships for late responding tissues are curvier than for early responding tissue. So this kind of relationship we can show you another figure that is really you get used to it by the late responding tissue and how is this curvier than the early responding tissue. Actually, we can. Okay, it's not here. Oh, it's chapter 20 already. Okay, we can take a break here. I'm gonna just jot some notes down into my docs and I'll be right back, or maybe I just record another video about this. Thank you so much, guys, for listening.